Okay, I think we stopped here and we have established we said that the lipoprotein has the protein part and it also has the lipid part. Okay, and these are the protein part of the lipoprotein and we call them hypolipoproteins. The ones marked in red, we said they are not good. Then the ones marked in black or the dark ones are good. So generally, if you check, ApoB is bad generally, be it ApoB 100 or ApoB 48, which is in the gastrointestinal tract. Okay, ApoA, E, and C, C2 are good. ApoC3 is bad. Now, the VLDL, IDL, LDL are bad. Okay, yeah. I think I've also explained this table, so let's not waste time on this table. Let's go straight into the fate of lipids. Now, aside the thiolane, we digest complex carbohydrate. We also have lipase in the mouth, in the oral cavity. We call it lingual lipase, which helps to digest your fat minimally. Then when your fat or lipids get into the small intestine, it becomes emulsified, and pancreatic lipase also breaks it down. So how will this lipid be absorbed? Micelles will be formed. I'm 100% sure you are used to the word micelle in your pharmaceutics. I don't know if you should have done that. Okay, so you are used to the word micelle. All right, so in the intestine, lipids are transformed into the enterocytes inside micelles. Okay, now in the enterocytes, you know, the lipids have been broken down. They become reesterified into triglycerides, and in these enterocytes, they form chylomicrons. Now chylomicrons enter the lymphatic system and then into the bloodstream. So it doesn't really go directly into the systemic circulation like that. It enters the lymphatic system first, then it becomes drained into the systemic circulation. Now triglycerides are broken down by lipoprotein lipase. I've explained this also on the fact that plants don't make cholesterol, animals make cholesterol, then how we plant fat contributes to high cholesterol. We have said this, and I think I explained the SFAs, MUFAs, and PUFAs. So primary means that it may have some genetic inputs. So when we say primary dyslipidemia, it means that it is caused by genetic mutations affecting lipid metabolism. So here we'll talk about things like familial in the literal sense means it runs in the family. The familial hypercholesterolemia, familial combined hyperlipidemia. Okay, so this is a primary form of dyslipidemia. Then the secondary form is the one which is caused by lifestyle. Okay, lifestyle factors and some underlying disease conditions. Take for instance diabetes mellitus, hyperthyroidism, then excessive alcohol intake. Now let me say something about alcohol intake. Moderate alcohol intake can raise the high density lipoprotein. Okay, studies have shown that. That's why some of the pro alcohol, we say that when you take alcohol, it helps the health and all of that. So moderate alcohol intake can okay, moderate alcohol intake can raise the HDL, but the unfortunate thing is that excessive alcohol intake can raise triglycerides. Okay, and you know the implication of raised triglycerides. So life is about balance, you understand. You cannot be on the two extremes. It's about balance. Okay, anyways, but recently the WHO will say you should not even take alcohol anyways, but studies have shown that moderate alcohol intake can raise HDL, while excessive alcohol intake will raise triglycerides. So let's go back to the forms now that we have differentiated primary from secondary. Okay, when we say hypercholesterolemia, these are just medical terms. It means elevated cholesterol or LDL, and of course we know that the LDL-C is called bad cholesterol. This can increase the risk of atherosclerosis, heart attack, and stroke. All these diseases that I've just mentioned will be what the HOD will be teaching you guys this semester. Okay, so you should be familiar with them by now. You should have introduced the class. Then hypertriglyceridemia is when the triglycerides are high, which results from excessive fat intake, excessive calories, and all of that. Like we said, that the severe cases can lead to pancreatitis. It can also in itself raise LDL. All right. Then we have mixed dyslipidemia. This is when we have elevated LDL, we have elevated triglycerides, and we have low high density lipoprotein, and it is common in metabolic syndrome and type 2 diabetes mellitus. Metabolic syndrome, I don't know, this might be useful anywhere. It's more like a syndrome that involves obesity, diabetes, and hypertension. These three, they really go hand in hand. Okay, once you have one, there's a tendency that you may have the other one. Okay, so they come under the umbrella metabolic syndrome. So hyper alpha lipoproteinemia is abnormally low HDL cholesterol. All right, let's move. So we said that the LDL is a bad cholesterol. All right, but there are some caveats that you guys need to know. All right, in fact, because medicine is emerging, all right, so you have to know this. Not all LDL particles carry the same amount of cholesterol. So person A may have fewer LDL, but each one may be loaded with cholesterol, and person B may have many LDL particles, but each one has the same amount of cholesterol as person A. So who is at more risk? Person B is at risk because person B has higher tendency for atherosclerotic cardiovascular disease than person A. This may not be clear to you, but let me explain so that you get it. Now, LDL itself has a protein portion, then it has a cholesterol portion. Okay. Now, if you have higher protein portion, you are at risk of having atherosclerotic cardiovascular disease, okay, than someone who has fewer protein portion but the same cholesterol as you have. Did you get that? Do you guys get that? I need you to get that explanation. So
no sir.
Okay, because I know it might be a little dicey, so I'm going to explain again. When we say lipoprotein, they are carriers of lipids in the human body, and we have established the fact that the LDL is the bad one while the HDL is the good one because of their mechanism of transport. Now, so these have protein portion, then they have the lipid portion. Now, you see, LDL, the protein particle alone, is a biomarker for ASCVD, for atherosclerotic cardiovascular disorder. Even the protein portion alone, without the lipid, can predispose you to atherosclerotic cardiovascular disease. That's what we are saying. So if patient A has fewer LDL, okay, the protein part or the particle part, and patient B has many LDL, but they both have the same amount of cholesterol carried by this LDL, patient B is at more risk of atherosclerotic cardiovascular disease than patient A, because patient B has more LDL proteins or LDL particles than patient A. Now, so in time past, what we measure, okay, what we measure medically is the cholesterol carried by LDL, but the paradigm has shifted to we getting to measure the LDL protein or the LDL particle itself, and not just focus on the cholesterol alone, because the LDL particle is a better biomarker than the cholesterol itself. I do hope you get my point. Okay, so that's why diagnosis these days is now tending towards measuring LDL particles or ApoB100. Why am I saying ApoB100? In the earlier slides, you saw that ApoB100 is the protein portion of LDL, VLDL, HDL. Okay, so recently, a better biomarker is either measuring LDL particles or measuring ApoB100. Do I need to explain this again, or you get the picture?
I can just go over it for a short time, just briefly, sir.
For a short time.
I just briefly.
Okay, now, we said that the lipoproteins, okay, carry lipids in the blood. Okay, they carry lipids. They are proteins that carry lipid. Now, in time past, we used to measure just the level of the cholesterol carried by these lipids. Okay, so you can measure LDL-C. That's the cholesterol carried by lipoprotein LDL. Okay, and you know that this LDL is made by the protein portion is ApoB100. Okay, unlike the high density lipoprotein. Now, so what I'm saying is, if a patient has more LDL particles than a patient A who has fewer LDL particles, but if their LDL particles carry the same amount of cholesterol, okay, patient B is still more at risk of ASCVD than patient A, although they have the same amount of cholesterol. The reason is because the LDL particle or the LDL protein itself is higher in patient B, and this is a cause for alarm. Okay, because another thing is that we can also measure ApoB100, which is the protein portion for the bad lipoproteins. Okay, so what I'm saying is that the focus should not just be on the cholesterol level, the focus should also be on the protein level. Since we already know that LDL carries cholesterol, okay, the focus should be less on measuring cholesterol and be more on measuring the protein that carries the cholesterol itself. So when the protein is much, it's a better biomarker of atherosclerotic cardiovascular disease. is kind of crazy, but I hope you guys got it. Okay, why? So let's explain. You see, the low density lipoprotein itself can slip into the endothelium. When we say the endothelium is the inner layer of your blood vessel. Okay, now it can. Okay, so when this LDL enters the damaged or inflamed endothelium, it becomes trapped and it interacts with free radicals and become oxidized into a toxic form. Okay, now macrophages absorb. Macrophages now they eat their forms of immune cells, your white blood cells. Okay, so macrophages absorb these oxidized LDL and turn it into foam cells. Okay, foam cells now accumulate. They can now form early fatty streak in arterial wall, like you are seeing in this our diagram. Okay, now the foam cell release chemicals, attract more immune cells, and this leads to chronic inflammation. Then the vascular smooth muscle cells migrate and form a fibrous cap. Foam cells die, their content form a necrotic core, plaque enlarges and can rupture, causing a clot, which can lead to heart attack or stroke. So the essence of this is that your LDL can enter your damaged or inflamed endothelium, okay, and cause a cascade rather of inflammatory events that will lead to plaque formation, which can eventually rupture and cause heart attack or stroke. So we have established that our body makes most of the cholesterol, more than half. Then we get the other from food. So let's go into cholesterol synthesis. This is not all the diagram, but cholesterol is made from 2-acetyl-CoA, 2 molecules of acetyl-CoA, and all of that. The most important thing we need to know here is our hydroxymethylglutaric-CoA synthase. Okay, this enzyme makes the 3-hydroxy-3-methylglutaric-CoA now, and HMG-CoA reductase now reduces this to mevalonate. So the most important, the rate limiting step in the synthesis of cholesterol is the action of HMG-CoA reductase. HMG-CoA reductase. Now, so it is this HMG-CoA reductase that the statins target. That's the enzyme that the statin targets. Okay, and also the HMG-CoA reductase is the rate limiting enzyme in cholesterol formation. Now, so what are some of the pharmacological interventions for dyslipidemia? We have small molecules, peptides, proteins, monoclonal antibodies, vaccines, RNA therapeutics, gene therapy. So let's start from the small molecules. We have statins, ezetimibe, PCSK9 inhibitors, omega-3 fatty acids, bependoic acid, bile acid binding resins, fibrates, niacin. Okay, so among the ones that are not statins, there are 3 that are very strong. Okay, that are considered for managing LDL-C. We have ezetimibe, PCSK9 inhibitors, bependoic acid. But for triglycerides, cholesterol is different from triglycerides. For triglycerides, we have omega-3 fatty acid preparations. Okay, while the other ones are less important, but we still have them in the market. Okay, so but the 4 that are important for LDL-C, for if you want to manage cholesterol, high cholesterol, ezetimibe is important, PCSK9 is important, bependoic acid is important. Then if you want to manage triglycerides, hypertriglyceridemia, then we have the omega-3 fatty acids. Now, so let's take statins. Let's take statins. Please, if you have any question, let me know. We have so many things to deal with, so I have to be very fast. Now, statins are still the cornerstone when it comes to small molecules. Statins are the cornerstones of nearly all regimens for treating dyslipidemia. And 4 group of patients will benefit from statin medications. We have adults with diabetes mellitus, okay, because diabetes will increase your chances of dyslipidemia and atherosclerotic cardiovascular disease. So adults with diabetes mellitus will benefit from statins. Those with existing atherosclerotic cardiovascular disease will benefit from statins. And if you have a low density lipoprotein cholesterol greater than 190 milligram per dl, the person will benefit from statins. Then if you have a 10-year risk of atherosclerotic cardiovascular disease greater than 7.5%, the patient will benefit from statins too. So these 4 categories of patients, we have those that we use statins for primary prevention, and we have those that we use statins for secondary prevention. Like those with existing ASCVD, we use for secondary prevention, while some we use for primary prevention. There is a ASCVD calculator online, so you can calculate your risk of atherosclerotic cardiovascular disease. If you are a smoker, your risk jumps up exponentially. Okay, so the calculator is there. You have to input you have to answer some questions on lifestyle, answer some questions on blood pressure and all of that. Then it calculates your risk of having an atherosclerotic cardiovascular disease. Okay, I think once in a while it's important you check that up, and in your course of practice also you can use the calculator for your patients to know their risk of atherosclerotic cardiovascular disease and how they can start primary prevention immediately. So our statins target HMG-CoA reductase. Okay, it targets the HMG-CoA reductase, which I have shown you in the conversion of acetyl-CoA, or in the synthesis of cholesterol from acetyl-CoA. Now, because this HMG-CoA is the rate limiting enzyme in the formation of cholesterol, all right? Now, when you use statins inhibit this enzyme, and when statins inhibit this enzyme, cholesterol synthesis reduces. Okay, then there is also a compensatory increase in hepatic LDL receptors. So, and I told you that when LDL receptors increase, okay, they take up LDL-C from the blood and metabolize them. Okay, please note, statins do not increase LDL-C. It increases hepatic LDL receptors, and these LDL receptors can mop up LDL cholesterol from the blood and metabolize. All right. Now, statins also decrease circulating, obviously, low density lipoprotein cholesterol by 50% or more, depending on the dose you use. Then they can also modestly increase high density lipoprotein levels and substantially reduce triglyceride. Also, they can reduce high sensitive CRP levels. Now, statins can be categorized into two. We have let's say three: high intensity, low intensity, or moderate intensity. And this all depends on the dose. Okay. High intensity will reduce low density lipoprotein cholesterol by approximately 50%, while moderate intensity or low intensity will reduce by, let's say, 30 to 50%. So it depends on dose. So for high intensity, we have atorvastatin 40 to 80 milligrams per day. We have rosuvastatin 20 to 40 milligrams per day. Okay. Please, CRP here means what's it called now? C-reactive protein, and it's a marker of inflammation. The statins also help to reduce this. Now, your atorvastatin 40 to 80 milligrams per day is high intensity. Rosuvastatin 20 to 40 milligrams per day is also high intensity. I personally prefer atorvastatin and rosuvastatin for dyslipidemia, but we have other ones like simvastatin, pravastatin, and all of that. Then if you want atorvastatin and rosuvastatin, most people start with low intensity or moderate intensity atorvastatin and rosuvastatin. The reason is because of side effects. Okay, and most people don't go into high intensity, because if you move into high intensity, it also increases your chances of adverse effects and side effects, which we will get to mention very soon. Okay, so let's go into the ADME: absorption, distribution, metabolism, and excretion. Now, all statins are administered in their beta hydroxyacid form, except for simvastatin and lovastatin. Because that's the form that inhibits the HMG-CoA reductase. Now, simvastatin and lovastatin are administered as inactive lactones. Then they are transformed in the liver to their respective beta hydroxy acids. So it's safe to say that simvastatin and lovastatin are more like prodrugs. Okay. Now, then there is excessive first pass hepatic uptake of all statins, and this is mediated by organic anion transporter, OATP1B1. That's why simvastatin and lovastatin are administered in their prodrug forms. Now, hepatic cholesterol synthesis has a chronobiology. Okay, chronobiology, we use it a lot in pharmacology. You must know the chronobiology of your medications so that you know when and how to advise your patients to take them. So cholesterol synthesis has a chronobiology, and its synthesis is maximal at midnight and around 2 a.m. Okay, most statins have very short half-life of about 2 or 4 hours, except for atorvastatin and rosuvastatin. So most statins are taken in the evening to match the chronobiology of hepatic cholesterol synthesis. Are you guys following?
Yes, sir.
Yes, statins are used in the evening. Let this stick to your head now. Now, when you see any prescription of statin, except for atorvastatin and rosuvastatin, which have long half-lives, there must be nocte. If you are not seeing nocte, then you advise your patient to take them in the evening to sync with the chronobiology of cholesterol synthesis. Note my word of chronobiology, because if I ask this in your exam, when we get to the pharmacology of the adrenal gland too, I will use the word chronobiology. Okay, we can also say chronopharmacology, because there is a chronobiology to cortisol synthesis also, which affects how you use corticosteroids. All right, so all statins should be used in the evening. The only exemptions are atorvastatin and rosuvastatin, because they have very long half-life, which can also cover for, or which can help sync with the chronobiology of cholesterol synthesis. Okay. Then the metabolite of all statins, except for fluvastatin and pravastatin, can also reduce cholesterol synthesis. Due to the extensive first-pass metabolism, which I've talked about earlier on, the systemic bioavailability of statins can vary between 5% to 30%. Although now in pharmaceutics and pharmaceutical technology, they are using nanoparticles to formulate so that oral bioavailability will improve. What is bioavailability? That's your elementary pharmacology, whatever. What is bioavailability? Let's see if you still remember. What is bioavailability? What is bioavailability? Colade, what is bioavailability? It's a lie. Nobody knows bioavailability. It is well. Let's. Colade, yes, I'm listening. You have the floor.
Amount of drug is available at a particular part of the body, particular time.
Amount of drug available in a particular part of the body. Partially, I will accept that, but not totally. Anyway.
Sir, the amount of drug that reach systemic circulation.
Okay, I will also accept that, but not totally. At least maybe 75%. Any other person? Yeah, Omotosho, go ahead.
Is the amount of drug that reaches the systemic circulation in the unchanged form?
Through the what?
In the unchanged form.
Unchanged form. That's the perfect definition. It has to be in the unchanged form, not the metabolite reaching the systemic circulation. Okay, so that's why I'll give 100 for that definition. It has to be in the unchanged form. All right, thank you, Omotosho. Okay, so let's continue the hard name. Atorvastatin and simvastatin are extensively metabolized by CYP3A4. Now, see, if you don't know any cytochrome P450 enzyme, you must know CYP3A4 and probably CYP2C9. Any drug metabolized by CYP3A4 would have several drug interactions. Okay, so please take note of that. In fact, in drug discovery, we always keep in consideration metabolism by CYP3A4 and CYP2C9, because most of drugs that are metabolized, particularly by CYP3A4, we have extensive drug interaction. So please take note of this. Atorvastatin and simvastatin are extensively metabolized by CYP3A4, while fluvastatin and pitavastatin are metabolized by CYP2C9. CYP3A4 have more drug interactions compared to CYP2C9 one. Okay. Because the reason is because CYP3A4 metabolizes about half of all drugs on the market, and many more commonly used drugs are moderate potent inhibitors or inducers of CYP3A4. So that's why it's a call for concern when a drug is metabolized by CYP3A4. Okay, CYP2C9 also has clinically important drug interactions, but it metabolizes fewer drugs compared to CYP3A4. Now, why are we saying all this? We are saying all this so that you know that there should be a distinction between a pharmacist in medical practice. All right. Take for instance, if I throw a question and say, okay, justify the reasons why rosuvastatin may be the most superior statin available in the market. Okay, so your justification will start from the fact that rosuvastatin has a very long half-life, hence it can be dosed in the evening. Okay, I'm telling you how we phrase our questions, and you people will not come out of the exam and say, that man is stupid, he did not teach us, he just brought it out. You know, we teach generally, but by the time we want to compose questions, we do a network. I pick from every page of that note and draft my question. So if I ask you a question like, justify why rosuvastatin may be the most superior or the superior statin available in the market. If I'm going to answer that question, we start and say that it has a very long half-life, then it can be dosed any time of the day, not necessarily in the evening. Then I can say it is not a substrate for CYP3A4. Hence, it has minimal drug-drug interactions. Okay, atorvastatin also has a very high half-life, but it's a substrate for CYP3A4, and so it can undergo like several drug-drug interactions. These are just the few justifications for why rosuvastatin may be superior to all other statins. So, another justification is rosuvastatin is the most potent. All right. Then, of course, because it's not a substrate for CYP, it has a lower potential for drug interactions. All right. And this is safer for polypharmacy. What is polypharmacy? What is polypharmacy? Any responsible person? Omotosho, yes.
It's like when a patient has chronic condition and there's a multiple medications at the same time.
Okay, yes. Usually, polypharmacy is a common thing for elderly people. They give them statin, give them antihypertensive, give them beta blocker, give them this one. So, rosuvastatin can be good for polypharmacy. What is the difference between polypharmacy and polypharmacology? Anybody that knows? What's the difference between polypharmacy and polypharmacology?
I don't know.
Okay, let me help you guys. Polypharmacology is when you use a single drug, but it has multiple mechanisms of action, and as a result, can be used for one or two conditions. That's polypharmacology. So it's about multiple mechanisms of action, and that's the common thing about phytocompounds, like your flavonoids, your alkaloids. They can be antioxidant, anti-inflammatory, anti-something at the same time. That's why you see people who are marketing herbs. They will say that in Yoruba, there's a term they call it gbogbo nishi. It means panacea, like it can treat so many things. That's polypharmacology. Most natural products or most phytocompounds are polypharmacologic in nature, meaning they have multiple mechanisms and as a result can fit into one or two things. But polypharmacy is when you are using different drugs to address different things, multiple drugs. Okay? So then rosuvastatin is the most potent. Let's move into the next thing. Any question? So the half-life of atorvastatin is 14 hours. It can allow for once daily dosing with a longer duration of action. Rosuvastatin has a longer half-life of 19 hours. It's also suitable for once daily dosing. Simvastatin, lovastatin 2 to 4 hours, pravastatin 1.8. So, but they are administered in the evening to sync with the chronobiology. Side effects: lipophilic statins. This is another reason why I am choosing rosuvastatin as the superior statin. Okay, so let's take a look into this. Lipophilic statins easily penetrate the tissues. You know, synthesis of cholesterol is in the liver, so the target of this drug is the liver. That's the target. But lipophilic statins can penetrate into other tissues, non-hepatic tissues, and cause broader effect like muscle pain. You see, particularly when you use high intensity, the muscle pain can be so severe that it leads into rhabdomyolysis. It can first start as myalgia, muscle pain, mild muscle pain, myalgia to rhabdomyolysis. Now, hydrophilic statins like rosuvastatin, pravastatin, these are more selective for liver tissue and they reduce the risk of non-hepatic effects, okay, which makes them potentially safer for muscle-related adverse effects. So these are reasons why rosuvastatin might be more expensive than all other statins because it just fits into all our checks. Safety check, long half-life check, interaction check. You understand? So, and in fact, maybe this is a giveaway question. We already have a giveaway question, so people will not be disturbing me for AOC all the time. Okay. Now, so this might prevent some muscle-related adverse events. So statin majorly, the major side effect is this statin-associated muscle symptoms, SAMS. Okay, and it can range from mild myalgia to severe rhabdomyolysis, the muscle breakdown. The statin-associated muscle effects can occur with normal serum creatinine kinase. Sometimes creatinine kinase is the way we measure Mozuel.
It's just really from
Okay. So now, then, like I said, the side effect can also be severe to the extent of having rhabdomyolysis, which is a more severe tissue breakdown and all of that. When statins are taken with some other cholesterol lowering drugs like niacin or fibrates, these effects become more severe. Okay. Then when you take with erythromycin, antifungal medications, nefazodone, and cyclosporine, who knows why some of these drugs that are mentioned may contribute to the severity of the muscle side effects? Anybody that wants to tell us? Erythromycin, antifungal medications, who knows why? Who can tell us why? Anybody who wants to tell us why? People are not vibing this evening. What is happening? You are dry.
Probably because they are metabolized.
Motor, hold on. Let me hear from you. Probably because who said probably because? Go ahead. You are making sense.
So because they are because
Like that, so they develop that.
Okay. So everything still boils down to everything boils down to CYP3A4 inhibition. Okay. So what happens when erythromycin inhibits CYP3A4? What will happen? Anybody? Yeah, go ahead.
There's a buildup of statin in the blood.
Okay.
There's a buildup of statin in the blood, which causes blood toxicity.
Okay, yeah, that will cause the accumulation of statins in the blood, and it can lead to more pronounced toxicity. Because these statins work in the liver, there's a risk of hepatotoxicity. Okay, so and the way we check if your liver is okay is by measuring some transaminases. Okay, so and because this drug works in the liver, you have to first check the liver function of your patient before you initiate this therapy. In fact, it's because of this hepatotoxicity. That's why the FDA withdrew approval for combining statins with fibrates or niacin. So you should never combine statins with niacin or fibrates. We are saying niacin. In your premise, you may not see the name niacin. They may call it nicotinic acid. So they are the same thing. Nicotinic acid, niacin, they are all the same. It's the same molecule, just different names. Okay. Now, ezetimibe, there's a protein called Niemann-Pick C1-like protein, and this protein plays a crucial role in the absorption of cholesterol. It's primarily found on the small intestine, particularly the brush border that is rich in villi and microvilli. So once cholesterol is absorbed by the enterocyte in the small intestine, it gets packaged into chylomicrons. So ezetimibe is an inhibitor of this protein, and when it inhibits this protein, it inhibits the absorption of cholesterol into the small intestine. Now, so 70% is excreted in the feces. Once cholesterol is not absorbed, it gets excreted, and about 10% is excreted in the urine as glucuronide or conjugate. Please hold on. All right. So bile acid sequestrant inhibit absorption of ezetimibe, and the two agents should not be used together. I don't know if you guys have seen bile acid sequestrant before in the course of your CWES, but an example of bile acid sequestrant is cholestyramine. We also have some other ones that we are going to mention here. The bile acid sequestrant. Do not cholestyramine is also another example of bile acid sequestrant. Okay, are we on the same page? So ezetimibe, are you guys following?
Yes, sir.
All right. So ezetimibe inhibits. The simple thing is that ezetimibe inhibits the absorption of cholesterol from the small intestine. But once you see ezetimibe, just know that what it does is to inhibit cholesterol absorption from the small intestine. But of course, you know that it must have a protein target. So the protein is now NPC1L1, Niemann-Pick C1-like 1 protein. So that's simple. All right. Or let me say it's simple because I am a lecturer. So ezetimibe is available as 10 mg tablets, and this one can be taken at any time of the day with or without food. It can be taken with any other drug for dyslipidemia except bile acid sequestrant, which inhibits its absorption. Yeah, another protein that we have. We have proprotein convertase subtilisin kexin type 9. This one, you might not put this one on your status anyway. This is PCSK9. And what it does is just that it plays a role in the metabolism of cholesterol. And what it does is to regulate the degradation of LDL receptors. You know, I told you that anytime we have more LDL receptors, then there will be lower cholesterol, because LDL receptors in the liver will take up LDLC and metabolize the cholesterol. Okay, so the PCSK9 binds to LDL receptors on the surface of liver cells and mark them for degradation by lysosomes. Okay, so in a way, PCSK9 destroys LDL. They don't do that directly, but they just mark them. Once they bind to the surface of LDL, they mark them. All right, and once they mark them, they can be degraded by lysosomes. Is that clear? Do you understand that? You first have to understand that we need LDL receptors, a lot of LDL receptors, to mop up LDL cholesterol from the blood. So anything that will inhibit anything that will degrade LDL receptors will cause an increase in cholesterol level. So we need more LDL receptors. And this proprotein convertase subtilisin kexin type 9 marks LDL receptors for degradation by lysosomes. So do we need to enhance this protein or inhibit it? We need to inhibit the protein so that we can have more LDL receptors. That means you guys are following. I am not just reading out this thing, no, but a lot of what I'm doing is reading. But of course, I chip in some things that are also very important. So what do we do to proprotein convertase subtilisin, the PCSK9? There are so many interventions. Number one is that CRISPR-Cas9. I've taught you this for the PCSK9 gene. What do you remember about CRISPR-Cas9? Let's even start from there.
It's a gene editing tool.
What do you remember about CRISPR-Cas9? I trust that you remember. Go ahead, please.
I thought that to use majorly I think swapping of genes, like removal of genes that can cause side effects in the patient, then swapping it or transcription of genes to
Okay, you're right, but I was just expecting you to use the simpler term. Gene editing, gene deletion, knockdown, knockout. When you want to edit gene, remove a part from it and all of that. So that's CRISPR-Cas9 for you. Okay. So there are drugs that will slice out the gene that makes PCSK9. They are currently in clinical trial. Then we have siRNA. Who remembers siRNA? I taught you all of these things during drug discovery and development. Okay, so small interfering RNA. An example is inclisiran. Is also being made. You see, when for CRISPR works on the gene. If you still remember your protein formation, we have gene, then gene to mRNA, then mRNA to protein. So CRISPR-Cas9 works on the gene level. It edits the gene. Small interfering RNA will work on translation, not transcription. So small interfering RNA works on translation. So we have siRNA like inclisiran, made by Novartis, and this reduces PCSK9 production by 80%, and it's administered twice yearly. Isn't this beautiful? This is the beauty of drug discovery. You just go to the hospital, take your drug twice a year, and you are okay. No problem with cholesterol. You have enough LDL receptors in your body to mop up cholesterol. Okay, so and this reduces low density lipoprotein cholesterol by around 51%. Another thing we have is vaccines against PCSK9. And some of these are also in clinical trial. But of course, I may not ask you all these ones in clinical trial, but I may ask you to tell me the mechanism of action of inclisiran. So of course, you know that as a small interfering RNA, it interferes with the translation of PCSK9 gene into PCSK9 protein. All right. So it's pretty straightforward though. We also have monoclonal antibodies being developed. What will monoclonal, Jesus of Nazareth, why am I pronouncing this thing like this? What will monoclonal antibody do? Who still remembers? Okay, monoclonal antibodies neutralizes protein. It's just like antigen antibody reaction. So what they do is to neutralize the PCSK9 protein when it is being formed. You know, the ones I mentioned earlier on, they work before the formation of the protein. But just in case, maybe the formation eluded some of the drugs, then You can also use monoclonal antibodies to neutralize the protein. Monoclonal antibodies mop up the protein, just like in a similar way of an antibody destroying an antigen. All right. So, and this has been found to be 50 to 60% effective. Okay. And the two agents that have been approved are alirocumab and evolucumab. Now, and I also told you something, that if the name of a drug ends in MAB, then you should know that that drug is a monoclonal antibody. I said that in your 300 level, if you still remember. Okay, so if I say that, what is the mechanism of action of alirocumab in dyslipidemia? The fact that the name ends in MAB, don't even be thinking of anything. Don't chew your pen cover. Don't, just know that it's a monoclonal antibody and it neutralizes PCSK9. That's all. If you give me that, at least you get some. If you now use some very good pharmacological term, your grade will be up again. Okay, so these injections too, like the inclisiran, but their own duration is short. They are injected subcutaneously every 2 to 4 weeks, but they're expensive. Some of these things you have mentioned are expensive, and they can particularly be used for familial hypercholesterolemia. So bepindoic acid. Bepindoic acid also targets cholesterol synthesis in the liver, and it also leads to the upregulation of LDL receptors. You already know the roles of LDL receptors. Now, because bepindoic acid is not activated in skeletal muscle, it does not have all these muscle pain effects. Okay. Now, mevalonic acid is acetyl-CoA is changed into HMG-CoA, and HMG-CoA is reduced into mevalonic acid. That's the target of statins. But the step before then, the formation of acetyl-CoA from citrates in the tricyclic acid cycle is catalyzed by ATP citrate lyase. Okay, and this is the target of bepindoic acid. That's the enzyme bepindoic acid target. Okay, so that's just the mechanism of action of bepindoic acid. The efficacy of bepindoic acid is not as much as those of the statins and the ones I mentioned, because it reduces LDL-C by 17 to 20%, particularly when used alongside statins. The only drawback is that patients treated with bepindoic acid should be monitored for hyperuricemia. And you know that uric acid contributes to gout. So that means that bepindoic acid can aggravate gout. So let's go to the drug for triglycerides, omega-3 fatty acids, like we have mentioned before. Interestingly, omega-3 fatty acid is in your fish oil. Okay, so omega-3 fatty acids, we have eicosapentaenoic acid, EPA, and docosahexaenoic acid, DHA. They are just essential polyunsaturated fatty acids that must be consumed through diet. And in fact, this is one of the reasons that Mediterranean diet is recommended for everyone. It's like kind of like a healthy form of diet. You can read more about the Mediterranean diet. Now, the pharmacologic preparation of omega-3 acids, they are approved for hypertriglyceridemia as supplements. Okay, they effectively lower triglycerides. Their own concern is just triglycerides, and this can also help reduce cardiovascular adverse events. Okay. Then the bile acid sequestrant I mentioned earlier on, we have resins. They are mostly resins, like cholestyramine, cholestyramine, cosivilam. These ones are also available in the market. In our introductory class, I explained this to you, that cholesterol is used to make bile acids. Okay, and bile acid is important. Can you see the cycle? Cholesterol is used to make bile acid. Bile acid is important in the emulsification of fat in the intestine, and cholesterol makes it. Now, so when you mop up bile acid using a bile acid sequestrant, the liver will want to metabolize cholesterol to make more bile acid. So you are getting rid of cholesterol in the body. Please take note. Your liver metabolizes cholesterol, and one of the products will be bile acid, which is used by your small intestine. Okay, so when you mop up bile acids in the gastrointestinal tract, the homeostatic principle states that the liver should make more bile acid to balance things. So your liver now uses more cholesterol to make more bile acid. So that's the mechanism by which this works. This drug works anyway. Now, so the resins bind bile acids in the intestine and they prevent the reabsorption. Anytime there's a complexation or a chelation happening in your gastrointestinal tract, whatever is chelated has to go down through your bowels and get excreted. So your liver has to make more cholesterol to produce bile acids. They are not absorbed from the intestine. In fact, children between 6 to 11 years can also use them. Then I've seen in cases where people use them in hepatic diseases, liver diseases. Okay, so bile acid sequestrant also can increase hepatic LDL receptors, which further clears cholesterol, like we have said. Okay. In severe hypertriglyceridemia, do not use cholestyramine or cholestyramine in patients who have severe hypertriglyceridemia. It's contraindicated. A common complaint is bloating and dyspepsia in patients taking these bile acid sequestrant. Of course, because they are resins, and as resins are more like gums, they can swell. Then they also chelate or chelate your compound and all of that. They can cause constipation. And so, if you are going to give out cholestyramine to your patient or cholesterol, you must advise your patient to drink enough water to help with constipation. They can also interfere with some drugs, so it's better you do not use them with most drugs, particularly those ones listed here. But ideally, what we do is just that when you give out a bile acid sequestrant, you advise your patient to not take any other drug, all right? At least maybe a few hours before or after the bile acid sequestrant. We also have the fibric acid derivatives. These ones are agonists of peroxisome proliferator activated receptor, PPAR alpha. And this also significantly reduces triglycerides, and they increase high density lipoprotein cholesterol by 15 to 20%. This protein is a nuclear receptor, and when activated, what it does is just to regulate the expression of genes involved in fatty acid oxidation, lipid transport, and lipoprotein metabolism. Examples of these include clofibrate, gemfibrozil. Let's talk about nicotinic acid, because there's a particular emphasis I'm going to place on nicotinic acid. It stimulates a G protein coupled receptor, GPR109A, and this G protein coupled receptor inhibits cyclic adenosine monophosphate production in adipocyte, and this reduces triglyceride synthesis. So niacin is also used for hypertriglyceridemia. You know what a G protein coupled receptor is now. It's a plus surface membrane receptor that is coupled to G proteins. You have the G alpha, G beta, and the G gamma. And you know that they have second messengers. I believe you have done this in your 300 level. The side effect of nicotinic acid or niacin is that it can cause flushing. And this flushing can be reduced by aspirin when you give aspirin alongside. Niacin can lead to severe muscle pain when combined with statins, and so you should be cautious when you want to give niacin alongside your statins. Then it can also exacerbate gout and liver diseases. Another thing is that it has congenital abnormality, may be one of the effects. So this should not be used in pregnancy. Okay, ApoB100 is also a target, like I said earlier on. And why is ApoB100 a target? Because it's a critical component of the lipoproteins that are bad, like the LDL, VLDL, IDL, and so it can also be a target for this for dyslipidemia generally. An example is mipomycin, and anytime we have sen ending a drug, you may not have to think twice. It is an antisense oligonucleotide, and what it does is similar to your small interfering RNA. Okay, so it also inhibits the translation of that protein. This is an approved drug too, but it's an antisense oligonucleotide. Please know all these mechanisms. Okay. ApoC3 also has an antisense oligonucleotide, and it's called volanisocen, and it's a protein that inhibits ApoC3, and like we said, ApoC3 inhibits the breakdown of triglycerides. So these antisense oligonucleotide can help combat this. All right, I believe with this, you'll be able to read and understand this lecture note. For the lipoprotein apheresis is more like dialysis. You filter out lipoprotein or the low density lipoprotein cholesterol. You filter it directly out from the blood, like you are doing dialysis. You know, for dialysis in a patient with renal failure, you gain access into the systemic circulation and filter out protein wastes, urea, and all of these things that are toxic to the body system. So, in the same way, particularly in familial hypercholesterolemia, you can gain access to the central circulation and filter out LDL, low density lipoprotein cholesterol, directly from the blood. So this is in severe cases of when it has a genetic implication. You can filter out the low density lipoprotein cholesterol from the blood directly when there's need for it, when other measures are not working, particularly pharmacologic and lifestyle modification methods. Okay, so please, any question? Okay, just a recap. Like I said, if a drug ends in SEN, it is an antisense oligonucleotide. And what it works on is translation. Okay, so antisense oligonucleotide usually attacks mRNA, and you know mRNA is needed for translation into protein. Then if you also hear small interfering RNA, it works against translation. Okay, it prevents translation of that gene into protein. So, and usually these drugs that are small interfering RNA, they also have their own suffix. And once you see that, you should know that, okay, this is a small interfering RNA. Then for monoclonal antibodies, what they do is just to mop up the proteins. They attack the proteins and neutralize the protein. So when a drug ends in MAB, it neutralizes protein. So at least this should be in your memory, and you should be able to recall this when the need is needed, when it's needed for you to recall it rather. All right, if there are no questions, I'm going to reach out to Kolade on the next class on the pharmacology of the adrenal gland. Then we move to chemotherapeutics. Please enjoy the rest of your night.